Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dianne C. Martin, MD. Dr. Dianne Martin is an internist and infectious disease specialist. Dr. Martin attended medical school at the University of South Carolina. She did her internship and residency at the University of Kentucky. Dr. Martin conducted her fellowship in infectious diseases at the University of California Davis School of Medicine and at the VA Medical Center in Martinez. Dr. Martin is on staff at Washington Hospital Healthcare System.
So I'm Dianne Martin. I've been in Fremont for a really long time, and my specialty is infectious disease, and I also do adult medicine, internal medicine. And I'm talking today about shingles. If you have questions during the talk, you can raise your hand, or we'll do questions at the end, whatever's easier for people. Shingles is a very interesting disease, and the thing that kind of prompted them to have this talk was the advent of a shingles vaccine. And initially the vaccine was for people 60 and above, and now it's approved for people 50 and above. So this is what the shingles virus looks like, and it's actually called varicella zoster virus. And this is your take-home message. So it's varicella zoster. It shows up as a painful rash, very common in people over 50, and vaccine provides protection. So this is your take-home message. So this is what shingles typically looks like. I don't know how well you can see here, but it's in a band, kind of in a circle. And shingles itself comes from a Greek word which means belt, because most of the times it does start about the waistline, or the other word is girdle. This is the other part of the virus. This is the chickenpox virus. And most of us know this from childhood, and most of us probably in this room have had chickenpox virus. Children growing up nowadays have access to a chickenpox vaccine, which is given to kids in the pediatrician's office, and a second dose is required before they go to school. So the varicella zoster virus is very unique. It's what's called a latent virus, and it belongs to what's called the herpes family of virus. And most of us know about fever blisters or cold sores, which are herpes simplex. And this is a herpes virus in that it's a latent virus. The difference here is this virus does not go away. So once you get infected with this virus, it stays with you forever. As opposed to a lot of us may have had measles growing up or mumps growing up. You got them, they went away, and you're now immune forever. But the herpes family of virus stays with you, which is a lot of you may have had cold sores or fever blisters. You know, you tend to get them over and over again. Get them with stress, get them with sun, get them with infections. So this is a latent virus, and it stays in your system forever. The unique thing about the varicella zoster virus is it causes two different diseases. The first one is the chickenpox virus, which I showed you was the child, and most commonly this is in children, but can occur in adults. It's what they call a primary infection. It's the first part of the infection. And it causes a generalized rash. The rash in chickenpox is all over. It tends to start on the trunk area but go all over face, arms, legs. It's a generalized rash. And as you can see from the picture with the child, let's see if I can go backwards, nope. Okay, these are very single little blisters right here, here. And we term these as dewdrop on rose petal. So if you look at it for a doctor's perspective, it's a very pretty rash. So it's a very clear blister when it first starts out, and the base of it is a very rosy pink color. So we call it dewdrop on rose petal, as opposed to like measles, which is a very sandpapery, rough, kind of pimply looking rash, not a pretty rash like this one. So this virus is very contagious. It's contagious mostly airborne. So even though the rash is on your skin, it's actually systemic throughout your system, and it's airborne. A lot of these people, children, when they're infected, they cough, they sneeze, and it's aerosolized. So I don't know how many of you have seen a backlit picture of a sneeze. So you see the sneeze and there's a light behind it so you can see the whole spray and stuff. And that's how influenza is transmitted, and that's how this virus is also transmitted. Prevention. There is a varicella vaccine. It was originally developed in about the mid-90s. So most people who were born after 1990 have had this varicella vaccine, which is different than the shingles vaccine. So the second illness is what we call shingles. It's a little bit different. It's a reactivation along a nerve cell, and I'm going to show you a picture in a minute. And just like the first picture, it's a much more localized rash. Let's see if I go back to it. See, this one is very localized. It's just in one band here. The band can be anywhere. It can be down a leg, can be on your face, arm. Typically tends to be on the trunk. But you can look at this, it's a very clustered, as opposed to the one on the child, which is single vessels. This is a very clustered one. It's a kind of a grouping of these. This one is not contagious, although the virus is. And the virus is in the little blisters. So if you have had chickenpox, I've had chickenpox, and if I were to develop shingles, I would be contagious with the virus to someone who has not had chickenpox or the vaccine. But if I were to give the virus to somebody who's not previously been infected, they would get chickenpox, not shingles. So shingles is the second part of the illness, and that's what comes out later on in life. Many times it's obviously much more common in people over 50, over 60. And if there's any of you out here 80 plus and above, 1 in 2 of you will have this disease. So it's extremely common. So shingles itself, the rash, is not contagious because the rash comes from the virus you already have. But the virus is contagious to somebody who has never had chickenpox. So the person is contagious. And again, prevention is the shingles vaccine. And as we go into shingles, it's very painful, it's very debilitating. Most of the times the virus will come and go within a matter of a few weeks. But as we'll go into it, there is a complication that's called post-herpetic neuralgia, which is where the virus so scars the nerve system that nerve does not recover. It can be anywhere from painful to itchy to super sensitive, aggravated, and that can last forever. Most of the times better in about 6 weeks, maybe 6 months, but some people have this forever. So there is a shingles vaccine, and it's approved for people over 50. It's a one-time vaccine, as opposed to the varicella vaccine for children, which is 2 shots to the series. This is a single shot. So as I was talking about, the way that this virus reactivates is chickenpox, when it becomes latent or dormant, goes to sleep in your body, it goes and stays in the nerve cells in your spinal cord. And it's very interesting. We don't know why this happens or why it picks the spinal cord. But as you picture the child that has the chickenpox, those viruses then go internally and migrate into the spinal cord system. So when the virus reactivates, it travels along the path of the nerve. And we don't know why it picks which one. So it can be more commonly on the trunk, but it can also involve the face or the leg. Primarily, it's the sensory nerve, which is why it causes the pain, but it can also be the motor part of the nerve. So there are people who actually get such infection that it paralyzes the motor nerve. So they can have weakness. If they get it in the face, the eye will droop. My father-in-law had this, and he actually ended up with a foot drop. So he had the shingles, it was very severe, ended up with a foot drop, so he had to wear a brace for the rest of his life. So this virus travels along the nerve root. So the nerve root is somewhere along here. The virus goes along the nerve root and then picks an area to come up. And then you can see it sort of triggers these little blisters, and you'll see these clustering of these blisters together. So it's not the single blisters like you see in the chicken pox. These are clusters of blisters. And again, they'll follow the track of the nerve, which is why you get it down usually just one side, and it goes to the middle and stops, because the nerve roots just go around your side and down one side or another. So you very commonly will not have it on both sides. Very commonly it's on one side, one what we call dermatome, or one nerve path. Occasionally can be more than one nerve path, can be the one right above or right below it. But typically it's just one single nerve path, so it goes traveling down across like this. So risk factors. So why do people get shingles? The bottom line is we don't really know, but overall risk is 20% because it can occur in very young people. I mean, it can even occur in children. I mean, it's extremely unusual, but can occur in children. Most commonly it's in adults, most commonly over age 60. So over 60, it's as much as 50% of people will come down with shingles, and very, very high in your 80-year-old and above. Usually it's because of a weakened immune system, and that can be associated with cancer. So if someone comes along and is diagnosed with lung cancer, bone marrow cancer, breast cancer, these things trigger it. Chemotherapy itself can also trigger it. Steroid medications can trigger it. Stress can trigger it. Stress is a big trigger. Organ transplant, somebody who's getting a kidney transplant, a bone marrow transplant, heart, lung transplant, this can trigger it. People who have HIV/AIDS are very prone to getting shingles. So this is what shingles typically starts with. Most people don't really sort of pick it up. It's kind of a itchy, burny kind of rash. It can be tingly. The pain can be very sharp, stabbing. And if you can sort of figure out where this lady is scratching, that's right close to her gallbladder. So a lot of times people think they have gallbladder trouble. This has happened to me once before. I had a patient who had this pain. I was sitting in the ER trying to figure out what was going on. And I called in the gastroenterologist thinking she had gallbladder trouble. He lifts up her shirt, and lo and behold, there's shingles. So, I mean, it masquerades a lot. It can also show up as like kidney stones. It can show up like as a heart attack. We've had people who have chest pain, and we were working up thinking they got a heart attack, and lo and behold, it's shingles. So the pain can be different in different people. The intensity is different. The other way this can show up is looking like the flu. So you can have fever, headache, you feel sort of sluggish, you're sensitive to light, and again, it can look like this before the rash starts. So this can, the prodrome, or the itching and fatigue part, will start anyway from 4 to 7 days before the rash is there. So a lot of times we're struggling trying to figure out what a person has before the rash starts, and when we see the rash, it's very typical. A lot of times we can almost diagnose somebody, they call in and say, I have this rash and it's in a circle, and we're pretty sure it's shingles. So symptoms of shingles are the paresthesia, which is the 50-cent word for itching, burning sensation. And again, it can be very sharp, throbbing, stabbing. It can be very intense. And it can present as fever, headache. The rash usually starts in a few days and usually is on the trunk area, but can involve the face, the arm, the legs. The pain can be anywhere from mild to severe. Sometimes we think the more severe the pain or the more intense the itching, the worse the viral infection and the worse the complications. The blisters themselves lead to ulcers, and then those ulcers later crust over. When the virus has then crusted over, that person's no longer contagious. So these are two other kind of blisters, just to kind of show you a lot of things mimic. So one of them is the cold sore, right here, which is the other herpes virus, herpes simplex. And then the other blister here is poison ivy. And again, you can see a little clustering, and then these are the single blisters. So you can see a lot of this will mimic, but you shouldn't see the pattern of the line of blisters. Usually cold sores is very clustered, very tight cluster, and then the poison ivy again is clustered but maybe patches of cluster, so it may be spread out. In other words, if you were out hiking or something, you might have it all over your arms or your legs. But shingles itself is in a band. It follows the path of the nerve root. But you can see how these look very similar. So the complications of shingles. So the most important complication is what we call post-herpetic neuralgia. And this is a very persistent pain, burning sensation, and it's where the infection has traveled along the path of the nerve root and has actually burned it or scarred it. And sometimes the body will heal. Medication can help it heal faster. Steroids sometimes make it heal faster, but for some people, this doesn't heal. And this is a very serious complication, and it can last for years. And people have it where it kind of comes and goes, but it's very debilitating. Sometimes when people get this, they lose weight, they have headaches, they get depressed, and they just don't feel good at all. And it's really hard to go out and participate in your life when you're here in your golden years and you feel crummy. Usually it occurs in about 10 to 15% of cases. It's going to be much more frequent the older the person is, and sometimes the more severe the older the person is when they get it. Because of the blisters crusting over, many times people will get a secondary bacterial infection because we all carry bacteria on our skin. And as itchy as this thing is with people scratching, basically you're going to bring the bacteria that's on your skin into those blisters and cause infection, usually a staph infection. The other complication is blindness. And I'll show you a picture in a few minutes where the virus has traveled along the path for the nerve root along the top of the eye. And it can get into the eyelid, can get into the cornea, can get into the retina, and can cause a droopy eye, can cause blindness, and those are not reversible. Those are not fixable. So this is one thing where the vaccine comes in. It prevents this. The vaccine reduces the incidence, it's not 100%, reduces the incidence of shingles, reduces the incidence of the neuralgia, and especially complications like the blindness, the infections, and the nerve damage. So treatment. So now we have somebody comes in, they have shingles, we've identified, okay, you have shingles. So what do we have to offer? They didn't get the vaccine, they now have the shingles. So we try to keep the blisters clean and dry because if they're scratching, they're going to get infected. We have antiviral medications which work pretty well. One of them is acyclovir. This is generic. It needs to be dosed about 5 times a day for 10 days. Cost at the pharmacy is about $40. Acyclovir is a newer drug, still comes generic. It's a shorter course. It's treated 3 times a day over 7 days. Cost of that is about $250. This drug actually does, in studies, reduce the amount of the post-herpetic neuralgia. So it's actually a little bit better than the acyclovir in terms of reducing the complications. Not 100%, but does give you a little bit more benefit. We get more benefit if the person comes in early. We can start on the acyclovir or the famciclovir early. So if somebody waits a week or 2, we would still give them the medication, but it's not going to work as well if they had come in earlier. So if you don't get your shingles vaccine and you do see it, call your doctor ASAP. We recommend the acyclovir or the famciclovir for everybody. Whether you're a 20-year-old with it, you're a pregnant lady with it, you're a senior with it, anybody who has shingles should be treated because it can reduce the complications. The antivirals also speed the healing. They reduce the severity, they reduce the duration. So we can bring it down. The duration of the rash is probably between 10 to 14 days. We can bring it down to about 7 to 10 days. So we can almost bring it down in half. But again, it's much better if we start sooner rather than later. The other thing that a lot of times people need to do because it's so intense, the pain or the itching of the blisters, is we recommend topical creams. Most of these are steroid creams. You can buy steroid creams over the counter. Those are not as potent as ones that are prescription strength. Oatmeal in terms of topical oatmeal creams, oatmeal soaps, oatmeal lotions. You can put oatmeal in your bath water and just kind of use it like a compress or something. That works really well. There are brand names of oatmeal, but I'm not supposed to say brand names. Calamine lotion also is very helpful. Many times we will give patients oral steroids. Now there are contraindications for steroids. If somebody has diabetes or high blood pressure or cancer, we probably would not want to give them oral steroids. But steroids do reduce the duration of the virus, slows it down, and also cuts back on the postherpetic neuralgia. So if possible, we really want to put somebody on steroids. And again, we're talking a fairly short course, so we're not talking months and months. We're talking maybe 2 weeks of steroids, starting with a very high dose and then tapering or cutting back over time. And that will reduce the postherpetic neuralgia, reduces the pain, reduces the duration, reduces the intensity, reduces complications. There are transdermal patches which work very well for the blisters, and there are name brands of those. One is called a lidocaine patch, which is a prescription, and your physician can prescribe that. That works very well as well. The blisters need to be a little bit dry because you're putting a patch on top of it. And there are also pain medications. So there's narcotic pain medications and then other non-narcotic medications which work very well as to control the pain. This just shows you some of the topical creams that we can use, and that, we usually encourage people to be very generous. If nothing else, it stops the scratching and the itching, because that can lead to a secondary bacterial infection. So that I feel like the more they put the lotion on or the cream on, the less scratching they're going to do, the less infection they're going to have. And then these are some of the brands of the oatmeal stuff that you can buy, and the calamine lotion. And those are all over the counter. So for complications, what do we do? And again, the secondary skin infections, the staph infection, so we sometimes will put people on an antibiotic, so like a penicillin or a cephalosporin antibiotic, and usually short course, usually it's just tablet antibiotics. We don't need to treat them long term. The eye infection is very serious. So if there's any indication that somebody has it in their eye, it may feel like just a little bit of a scratch or a burning, or sometimes they have vision problems, but anytime we suspect the eye infection, this is very serious. This is emergency. We want to get them to an eye doctor ASAP. The eye doctor has a slit lamp, which a lot of times if you've been, you put your chin on the bar and they have this light that goes back and forth like that. What they're looking at is the very front part of your eye, the cornea. And what happens is with the shingles eye infection, it gets into the eye and the cornea and destroys the cornea. It can also get into the retina, but this is the most serious part. So they're antiviral eye drops. So we still would give somebody the acyclovir or the famciclovir tablets, but we'd also add the antiviral eye drops. We want to make sure that they see an ophthalmologist and have the cornea and the retina checked, and that they need to follow up very closely. If it gets this severe, most of the times these are patients where we end up admitting them to the hospital, because we will give them oral acyclovir and famciclovir. We can also step it up a bit and give them IV medication. So the famciclovir and acyclovir comes as an IV. So a lot of times these eye infections are so urgent, severe, emergency, we actually admit them to give them IV medications, and that way the ophthalmologist can monitor them very closely. Sometimes, depending on the person's immune status, the virus won't stay in the dermatome. It won't stay in the one pattern, the one band. It becomes more generalized. This, again, is very serious and indicates the person's immune system is very weakened. This can occur with patients that maybe have chronic dialysis, cancer patients, HIV patients. Those patients also need to be hospitalized. That, again, is emergency. And those patients need intravenous antiviral medications, not just tablets. Complications, again, are more serious if somebody is immunocompromised, cancer patients, somebody who's had a lot of weight loss, stress, chronic dialysis, chronic cardiac patients, chronic emphysema patients, diabetic patients. Any of those have a slightly weakened immune system, so we want to make sure that those people are followed very carefully for any complications. So again, this is the eye, and you can kind of see, again, the clustering of the blisters right across of here and going down. So this is the pattern of the nerve. So where we saw it in the other gentleman, where it's kind of a circle going around the waist or around the trunk or down the leg, this is coming down from just above where the scalp is, coming straight down. This is the path of that nerve. And you can see how red and how swollen this eyelid is. And you can, if you kind of pretend you can kind of see the redness here, that's where the virus has gotten into the cornea. This is emergency. Yeah, so you can see how unhappy this person looks too. I mean, this is very painful, very uncomfortable. I mean, you can sort of visualize if you get like an eyelash in your eye or a little piece of grain of sand, you kind of wash it out and you're all better. This stays like that for a couple of weeks. This is very painful. So we give them eye drops, try to make the pain as best controlled as best we can. This also tends to be the one that's going to go to the postherpetic neuralgia. These are so serious. This is the one who's going to have the nerve damage later on. I mean, the eye damage is one thing, but the nerve damage is going to be very severe for this person. So a lot of times these people think, oh, I'm using some cream I'm allergic to, or I got poison ivy, or something like that. These are very serious. So if you see this, this is emergency. This is go to ER, get your doctor to check you, go to your eye doctor. So you can have it in the eye or to the side of the eye. It just depends on what path the virus takes. So not all facial shingles involves the eye, but to me, if I saw that, I'd say you need to get your eye checked anyway. A lot of times they'll have a little bit of dryness or irritation, and it may be minor. And for me, I'd much rather be sending you to the eye doctor and it's minor and nothing than to say, don't worry about it, and then it's something more serious. Okay, so late stage. Again, this is the neuropathy, the postherpetic neuropathy. This is very frustrating to treat because a lot of times there just is no one right thing that's going to fix it. Again, if we get the person in sooner, we get them started on an antiviral sooner, we get the pain controlled, the postherpetic neuropathy is going to be better. And I can't tell you it's a whole lot better, but it's usually much better than if it lingers, or you sort of put off coming in until you've had it a couple days and say, oh, maybe I should go in. So we can give them analgesics, we can give them narcotic and non-narcotic medications. There are anti-seizure medications. And again, a lot of people say, well, why are you doing that? But a lot of times we find that drugs that started out their life as one particular type of drug found out its life was much better doing something else. And the very typical example that I cite is Viagra. That started out as a heart drug, but was not very good, but did work for other things. So these two are seizure medications, which are really not very good seizure medications, but they are very good in terms of pain control. They do have side effects. They tend to make people a little bit sleepy, a little bit groggy, but in terms of pain control, they are very good. So in terms of treating postherpetic neuralgia, these are outstanding. The first one is gabapentin, which also comes as a generic. The other one, pregabalin, is a brand name drug. And again, these are prescription medications. You would need to go to your physician to have these prescribed. But these work very well. The other thing is the tricyclic medications, which are actually, again, antidepressants. We're using them in different dosing. So the tricyclic antidepressants for depression usually is like 300-400 milligrams. These are very small doses. We're talking 25, 50, maybe 100 milligrams. Work very well for pain control. So again, we go through, our careers, we find out something works really well for something else. So in terms of pain control, this works very well. The other thing we sometimes do is nerve blocks. So a lot of you may be familiar with, you have a pinched nerve in your spine. Sometimes we'll give people steroid injections into the spine to relieve the nerve that's being pinched from like spinal stenosis or chronic arthritis. So we use that same technique to go in and block the nerve. So we go right in where that nerve got excited and caused the shingles, put in a steroid block, and actually it reduces the pain dramatically. And will also block the postherpetic neuralgia. Many times this might not work the first time, so we usually tell people kind of give it a couple days. If it's not working, we'll go into a second and then a third. Many times we try to limit it to only 3 injections because of the complications with the steroids, but it gives people very dramatic pain relief. I mean, it can cause a really miserable person to be much happier. And if you figure that somebody is basically very active doing things, I mean, you can't be sidelined because of just pain. And this is one thing that we have to offer, and I think a lot of people don't always know about it, don't always think to ask about it. The other thing is that we use is called capsaicin, which is this one right here. And a lot of you may know about this. This started out as ground up peppers, and it works very well for postherpetic neuralgia. It has a brand name, but it also comes generic, and it works very well. So it actually was originally a prescription medication that's now over the counter. Caveat is you need to wait until the blisters have crusted up a little bit, because the last thing you want to do is put this on an open blister. You will not be very happy. But this works extremely well, and it's something that you can buy over the counter. You can use as often as you like, and sometimes people like to have a little bit of control over what they're doing. And this one works very well. There are also topical anesthetics. So just like, there are anesthetic gels that people use like for dental work and things like that, we can use topical anesthetics. And again, that patch, that lidocaine patch I was talking about, that's a topical anesthetic that we can use. And again, the steroid injections work very well. So a lot of times people say, well, okay, so I've got this, I'm doing a little bit better, so when can I go back to work, or when can I go take care of my grandkids, or when can I go, hang out with my friends? So a lot of it is sort of like, it depends. If you have the facial blisters, you definitely want to wait until those are crusted over and you're in the healing stages. This is something we don't have people rush and go back to doing to work, or going back to doing your life, your volunteer work, babysitting grandkids, or whatever you're doing. This needs to wait. If the blister is in a covered area, so like the first picture where the gentleman had it on the trunk, that's something ordinarily we would be wearing a shirt or blouse or something like that. So if it's covered, or you can put a bandage over it, you can go back to doing your activities when you're feeling well. If somebody's in healthcare, because obviously they are working with people who are very sick already, and last thing they need is extra infections. We have healthcare workers wait until the blisters are completely resolved, so that there is no chance that they are going to give this virus to somebody who is not immunized or has not already had an infection. So healthcare workers, or somebody who works maybe at daycare or something like that, probably needs to wait until all the blisters are pretty much crusted over, healed up, and better. So this is again what the blisters look like. You can see a tight cluster, and it's kind of a string. It kind of cut it off a little bit, so you can see the close-up. And again, it's got that sort of, we call it a pretty rash. It's got the very clear blister and a very rosy background to it. So it's called dewdrop on rose petal. And this is what it looks like, kind of all crusted up. So you can see this person has a lot of virus in those blisters, and they are contagious for the virus to someone who has not had virus. So if they're around somebody who's already had the virus, so this is say like a spouse and the other person has had chickenpox, they're not going to catch it. Or if they're around grandkids that have had the vaccine, they're not going to catch it. But there's a lot of virus in those blisters. So this is why we have people wait until these blisters are basically crusted over, the virus is gone. Now you still have the complications of the virus, but the virus itself is gone. So prevention. So I want to talk a little bit about the vaccine. This is a live virus vaccine, so again, it cannot be given to certain categories of people. So not people who are getting ongoing chemotherapy, not pregnant women, not people who are immunocompromised. It was developed in about 2006 and was licensed in about 2008. And compared to the children's varicella vaccine, this is about, I think, 40 times stronger in terms of immune potential. Because what happens is when you get the infection, your body builds up an immunity, which is why you don't get chickenpox a second time. Can it happen? Yes, lightning strike twice, it can happen, but it's extremely rare. So once you've had chickenpox, you don't get chickenpox again. So your body builds up an immunity to it. You have antibodies in your system, so that's why you don't get chickenpox again. But as we grow older, your antibodies start to deteriorate, which is why the virus then becomes active again. So the antibodies that are in your system kind of keep that virus kind of quiet. And as long as your immune system is healthy, the virus just stays dormant. The word we use is latent. If your immune system starts to wane and the antibody levels drop, that's when the virus becomes active. And either triggered because of stress or chemotherapy or steroids or kidney disease, we don't really know. So what happens is with the vaccine, we're basically upregulating the immune system. So we're giving you, in effect, a booster, but it's a huge booster, which is why this vaccine costs so much money. So what it's doing is boosting your immune system. And that's why at this point we think that you only need the shingles vaccine one time. So it basically boosts up your immune system. So even if you're not sure if you've had chickenpox or not, because a lot of people say, well, there's 8 kids in my family and a couple did, and I'm not really sure, and my mom's not around to tell me, I don't know. We can do a blood test which looks for the antibody to chickenpox, but you don't really need that. The vaccine itself will protect you. So you don't have to know whether or not you've had chickenpox or not to get the vaccine. You can have it. And again, this vaccine has great impact. I mean, we can treat the shingles, I can give you the steroids, I can give people the nerve blocks, I can give them the antiviral medications, but I can't prevent it. I can't take away the symptoms and I can't prevent the complications. The vaccine is your best bet of this. Is it 100%? No, but it does reduce the neuropathy by at least 50%, and it reduces hospitalization and the eye involvement, which is so serious, by at least 60%. So the vaccine is recommended right now. It was originally for 60 and older, now it's 50 and older. Anybody who has chronic medical conditions, so be you diabetic, be you a cardiac patient, a COPD, a cancer patient, recent weight loss, stress in your life, anything. We also recommend it for people that live in assisted living facilities or skilled nursing facilities, because they are also more prone to being stressed or immunocompromised. It's not indicated for children. Children has the varicella vaccine. This is the shingles vaccine. We don't recommend it if women are pregnant. It's not recommended if you're allergic to neomycin. And it's not so much the neomycin like people use neomycin cream, like it's that triple antibiotic cream. A lot of times people get a little bit of blister. It's not a topical allergy, it's a systemic allergy. We don't recommend it if people are taking ongoing chemotherapy. Once the chemotherapy is done, yes, you can have it. A lot of times if we know somebody's going to be going through a chemotherapy program that's pretty prolonged and we have the opportunity for some time, a lot of times we'll give them the vaccine ahead of time. It's not indicated for treatment of shingles. So once you have the shingles, we don't give the vaccine. Some people think that they probably should be boosted, and that's something that's not totally clear. But if you've had shingles and somebody still wants to get the vaccine, you usually have them wait a year. The shingles itself actually upregulates your immune system, so it does almost the same thing that the vaccine does. So, but we don't give it at the same time that somebody has active shingles. If somebody has active tuberculosis and they're being treated, we don't give it. And other vaccines like the pneumonia vaccine, we don't give the shingles vaccine at the same time as pneumonia vaccine. A lot of you may be familiar with getting the pneumonia vaccine when you get your flu shots in the fall. That's perfectly fine. But pneumonia vaccine and the shingles vaccine at the same time is not good, because they kind of cross antibody each other and they'll knock each other out. So we don't recommend it with the pneumonia vaccine. So where do you get more information? You can call the National Library of Science at NIH. You can call cdc.gov for vaccines, and there's a phone number there, and I'll be happy to take questions. So the question is very, very good. So if I'm over 60 and I get the shingles vaccine, at what point do I know if I need a booster? If now I'm 60 and then fast forward I'm 80, do I need it? The question is, we don't really know. So they have done some fairly long-term studies where they look at the antibody titers, and they can actually measure it after somebody gets the zoster vaccine or the shingles vaccine. The antibody titers just go astronomically high. And then, because we figure that it takes, we sort of look at it anecdotally, because there's not really any research. So if somebody has chickenpox, we can see the antibody titers like this, and over time they kind of come down like this, which is why at 60 or 80 you're then more susceptible to getting shingles. So we're figuring if your titer is going down at 60, and it took when you were 8 till you're 60, so 50 some odd years to get down here. If you vaccinate somebody at 60, you'll probably keep them going for till they're 100. So we just use that as anecdotally because we know what the virus itself does in terms of antibodies. And if we booster it up at 60, I think we can keep you going until you're 100. So there's not been any long-term studies because the vaccine's not been out that long, but what we use is the data from natural infection in terms of the antibody levels and what happens after you get the vaccine, and the antibody levels just go up astronomically. It's the same thing if you were to get the infection. Your antibody levels just go skyrocket high. So that's why they don't really recommend the vaccine for somebody who has had shingles, although a lot of people get very concerned and worried about it and they want it, so it won't hurt, but whether it does a lot of good, nobody knows.
Follow-up question. So there are no life cycle studies on the effectiveness of the vaccine?
So the question is life cycle studies. So the short answer is no. But the other thing is, we also look at the children who were vaccinated with the varicella vaccine, which is a much lower titer vaccine. And so they were maybe mid-90s, so we're at least 20 years out. And we're not seeing any zoster in those kids. But, that's the other question is, do kids who got the varicella vaccine as a child, say like at 8 or 9, when they get to be 50, are they protected or do they need another booster? We don't know that question. But I think we can look anecdotally and tell seniors, your one dose will probably protect you for a good 30 years.
How can we build our immunity if you have some of the risk factors?
So that's a really good question. How can you build your immunity? I think a lot of times we look at what can you do. So if you smoke, quit. If somebody's doing drugs, quit. If you do alcohol, limit it. If you have stress, try to de-stress, yoga, tai chi. They have great courses here. And there's general things that build up your immune system. There's no specific thing that will make your immune system better in terms of a drug or an injection, but you can do it naturally. Exercise, eat right, get better sleep, and if you smoke, quit. So I wish I had a magic pill. You and I'd be on Oprah.
I've got a question right here, Dr.
Okay.
Thank you. Could you talk a little bit about the herpes simplex? Is this also a result of chickenpox virus, and could shingles be secondary to herpes simplex also?
Okay, so the question is, how does herpes simplex fit into this? So the herpes family of viruses has about 7 or 8 viruses in it. So there's herpes simplex 1, which we associate with fever blisters, herpes simplex 2, which is a genital infection, cytomegalovirus, and there's human herpes 6. And all of those are the same family of virus, but they don't cause any other diseases. So just because you've had fever blisters or cold sores does not mean that you are more susceptible to chickenpox nor more susceptible to shingles, because shingles and chickenpox is only one part of the herpes family. So the question is, you can get herpes simplex in various places. So most commonly, people get it on their mouth as cold sores, but people do get it on their cheek or their eye or something like that, or you can get it, on your back or something like that, and it does mimic varicella. There is a way where if the blisters are fresh, you can actually culture the virus and you can tell which virus it is. But the question is, if you had herpes simplex, if you had a cluster of viruses on your face and you weren't sure if it was herpes simplex or herpes zoster, how would you know? A lot of times we kind of go, herpes simplex is, again, itchy but very localized, and zoster tends to be kind of linear, a line of blisters, but it could be very confusing. So the bottom line is, I would probably treat both. Whether I thought it was simplex or zoster, I'd probably treat with the same antiviral medications. And if it's really close to the eye, just like you were saying, if you get zoster and it's on your face, I probably would have the person see an eye doctor too.
I've never had chickenpox, measles, whooping cough, anything.
Your immune system must be great.
But I was exposed to them. All my siblings had everything. I did not. I had smallpox. Now, should I have vaccination? Am I going to get shingles?
So the question is, you've had family members who had the infection. Many times other family members get a really minor case, and your mom is probably so busy taking care of the really sick ones, she didn't pay much attention to you. So you may have had the infection, but I would still get the vaccine. Whether or not you've had chickenpox infection or not, I would still get a shingles vaccine because it will protect you.
You mentioned that you shouldn't have the zoster shot if you had a pneumonia recently. What about just a flu shot recently?
I think it's okay with the flu shot, but not the pneumonia vaccine. Yeah.
I'll make a comment first.
Okay.
After watching my mom suffer from shingles after a severe car accident, when I turned 60, they offered me the shingles vaccination. And at the time, they said, well, we're not sure if your insurance is going to pay for it. And I said, well, how much would it be? It's about $270 if they don't pay. It turns out that they did pay, but frankly, after watching her suffer for a really long time with active case of shingles, and then she's still suffering 20-some years later, it's like I would have paid $1,000 for the vaccination because of watching her suffer in agony, having that. I mean, it'll be the best money you ever spend if you actually, you'll never know if it works well, but after watching that, it was worth it. And how often do you see people becoming active shingles from no known cause? You know, I'm not sick, I'm not under stress, it just kind of occurs.
So the anecdote that he's talking about is, you know, watching somebody who has the complications, and it's pretty traumatic. I mean, I saw my father-in-law live another 10 years with a foot drop, and he couldn't do so many of the things he loved to do. I mean, he loved to take the grandkids fishing and all the kind of stuff that he couldn't do. So the stress is hard to quantify because we each kind of hold stress differently. And some people cope with stress really well, and other people, you know, just go to, you know, just going to turn out a basket case. So there's no rhyme or reason why it gets triggered. We really don't know. I mean, I think there probably will be research eventually as to what triggers it. I mean, there are certain things we've identified as risk factors, but you know, that doesn't cover 100%. So thank you.
When you get the vaccine, are there side effects or possible complications?
So complications of vaccine, it is somewhat painful. So it's more painful than a flu shot or a pneumonia shot, but not as bad as a tetanus shot. So a lot of times people get a little bit of redness at the site. They can have a little bit of fever, but it's pretty minor. So I'd say almost no complications from it. Originally, they thought that people were going to get, the kids were going to get chickenpox from the varicella vaccine, but that hasn't happened either. So other than just a little redness at the site is about it. Good question. So the question is, she has post-herpetic neuralgia, has had it for many years. So the question is, should you get the vaccine or not? I would still suggest it. My guess is the benefit is not going to be as much as somebody who's never had an outbreak of shingles, but you know, I still would go in favor of it. Medicare Part D does pay for the vaccine, and it depends on what your Medicare Part D plan is, because some Medicare Part Ds pay like generics and some don't, and some have special, you know, pharmacies that they cover and don't. So I think it's worth checking with your Part D carrier if you're a Medicare patient and see if it is covered, because you're right, it's about $200. You can get it at some of the urgent cares carry it, Safeway, Walgreens, a lot of the pharmacies do carry it, and will bill your Medicare Part D if it's covered.
I should get it. Yeah.
I would recommend it.
Yeah,
I mean, at this point, other than your pocketbook, it can't hurt.
Yeah, thank you. I will get it.
Okay.
But I've been told Medicare doesn't cover it, you know.
Well, it is Medicare itself. So Medicare covers like pneumonia shots, tetanus shots, the flu shots. But for some reason, the shingles vaccine was covered under Part D. So you have to look at your Part D benefit to see. Some do cover, some don't cover.
Yeah, it's about $200.
It's about $200, $250, yeah.
Thank you.
So the question is somebody who has the post-herpetic neuralgia, again, it's somebody that's got a prolonged and protracted case. I would still consider like the steroid block And then also the other medications that I listed, the gabapentin, the pregabalin, and the tricyclics, I would certainly try those and see if they work, or the patches, or the capsaicin cream. All of those might help. So are those ones you've already tried? Okay, and the steroid block too? Okay. So you tried you tried the patches, the lidocaine patches too. Okay, yeah. Sometimes
Nothing takes away the pain.
yeah, you can see if your doctor will refer you to like a pain specialist, because sometimes they have some other things that they could try. So that, I mean, if that were me, that's what I would do.
I tried everything.
And then you're a perfect case for why we want to see people get this vaccine, just so they don't have your story. Yeah. Question?
Regarding the insurance, I got the shingles shot and got it at Walgreens, and someone told me, oh, the insurance covers that. So I called the insurance, they said, yes, we cover that. So I submitted it, and she said, oh no, it's only covered, they notified me, it's only covered if you have it at a doctor's office. Walgreens doesn't count.
Okay.
So I paid for it.
Yeah. So,
it's worth it.
yeah, so some of the urgent cares have it. There's an urgent care that's on Walnut that's next to the Smart and Final. They have it, and they cover. So that the problem with having it at the doctor's office, because we had it for a while, it has to it has to be totally frozen. It has to be maintained at a very low temperature. It is really hard to maintain that. So a lot of the doctor's offices, because of that, it's very hard to keep it in stock. And for a while there, it was back ordered. You couldn't even get it no matter what. So it's just really difficult to maintain in your office, because most of us don't have refrigerators or freezers that go to that temperature. So that's kind of a problem. You could try calling Pete Stark. He's running for office, and see what he says.
Well, I had chickenpox when I was a child, and shingles about 5-6 years ago. Would you recommend that vaccine?
So again, the question is, you had chickenpox and then had shingles. Do you need the vaccine? Almost always the antibody titer goes so high once you have had a shingles outbreak that you probably don't need the vaccine. We still recommend it, but if you didn't have the funds to pay for it and your insurance didn't cover it, could you forego it? Probably. We do see problems later on. A recurrent case of shingles happens very rarely, but does happen. I mean, there's some people who get shingles like over several times in the course of a lifetime. It's rare, but it happens. A lot of it depends on your immune system. So in other words, if you were looking at, you're going to be doing a bone marrow transplant next year, then I would say definitely I'd go get it. I mean, but if you're a pretty healthy person, limited medical problems, no heart disease, no kidney problems, no diabetes, none of that kind of stuff, then I'd say, could you forego it? Well, probably. The bottom line is it won't hurt, and whether or not it's going to help or not is hard to say. And right now there are a few research studies that are doing the antibody levels. So a regular lab will do an antibody to tell you if you had chickenpox, but they don't give you the levels. And that's what you need to sort of predict whether or not you're going to get the shingles. So the bottom line is it probably will help, but it won't hurt.
Oh, sorry. I have a question and a request.
Okay.
First, the question. It sounds like from your earlier discussion that the antiviral medications like acyclovir and famciclovir works on like getting rid of the symptoms, the pain, but I clearly get the impression that the nerve is not sort of healed, or if there's a damage to the nerve, it's a long time process and does not get healed. I just wanted to understand a little bit more why the antiviral medications do not heal the problem in the nerve. So that's the question.
So the question is, why do the antivirals not really help that much? Part of the problem is that as soon as the person is having that pain, that itchy, burny type pain, the nerve damage has already started. And so a lot of times we don't figure it out until the blisters show up, and at that point you're sort of, about 4 or 5 days into the illness, and again, then the person's got to figure out, oh, I have a blister, I have a problem, oh, get to the doctor, oh, get the prescription. And so you're way into the illness before you ever get the antiviral on board. So that's part of the problem. Not everybody gets post-herpetic neuralgia, and some people get mild cases and other people get like really severe cases, and there's no way to predict that. We do think that the more severe the itching, the burning, the more severe the inflammation, the worse is going to be the nerve damage. So that's why we try to get the antiviral in there. The famaciclovir is supposed to be the best in terms of reducing the complications of the post-herpetic neuralgia, but again, not 100%. It's a little bit better than the acyclovir, but again, you're paying a little bit more money for it than you would be for acyclovir. So again, it's a little bit of a, robbing Peter to pay Paul. Okay.
We have a question right here.
I'm sorry.
I have a question. If you have had shingles before, say 10 years ago, and then now you have lymphoma, which is in remission, would you suggest getting the shot?
The bottom line is it can't hurt to go ahead and get the shot. The question is, what's your immune system like? So we're looking at the antibody titers that will go way up after an onset of shingles. And the question is, how low are they? And there's, other than research protocols, there's no way to know what that level is. But if your cancer doctor has cleared you to get the vaccine, in other words, you're post the chemotherapy window, it wouldn't hurt to go ahead and get the vaccine.
Oh, yeah.
As long as somebody's not ongoing chemotherapy, ongoing radiation, or ongoing treatment, when their immune system has basically kind of come back up, because we don't want to give you the vaccine because it's a live virus on top of somebody with suppressed immune system, because that's very dangerous. But it would help boost your immune system and prevent any future outbreak. But the question is, trying to predict whether or not somebody's going to come down with another outbreak is very difficult. But it wouldn't hurt. So the bottom line is, it might help, but it won't hurt.
What are your chances of having it again?
I think they quote about 10–15%.
After having it the first time, I don't want to take a chance.
Yeah, that's kind of bottom line.
Okay,
yeah.
Thank you.
Okay.
I've had the shingles twice. Would I still need the vaccine? I wouldn't like to have it a third time.
The bottom line is it probably would help prevent anything. It won't hurt you. So getting the shingles vaccine would just prevent another case. I mean, yours is very rare, and that we don't usually see a second case, but it does happen. I mean, it's rare, but it happens. But then you're rare. Oh, you've been a great audience. Good questions. Thank you very much. This has been very, very good turnout. Thank you, guys.